Welcome to Somerset Medical Center's Health Talk. I'm Dr. John Buchek, Director of the Somerset Family Medicine Residency Program at Somerset Medical Center. On today's show, we're going to discuss a new treatment option for patients with sleep apnea. Somerset Medical Center was one of the first hospitals in the state to begin offering robotic surgery for the treatment of sleep apnea. We are pleased to have on our show today Dr. Amy Lazar, an ear, nose, and throat specialist and robotic surgeon at Somerset Medical Center, and Dr. Namita Joshi, the Medical Director of Somerset Medical Center's Sleep for Life program. Good afternoon, docs.
Hi, thanks for having us.
Thanks for having us.
Dr. Joshi, we talked about sleep apnea in detail on one of our other prior shows, but start us off by giving us an overview. Remind us of some of the key features of understanding sleep apnea before we talk about its treatment.
Sure. Obstructive sleep apnea is a condition where airflow during sleep is either reduced or completely stops. It's usually in the upper airway system, and there are many symptoms of sleep apnea, some of which we will be talking about. Snoring is typically one of them, and is diagnosed using an overnight study called a nocturnal polysomnogram, which is usually the gold standard test.
And that testing is done after meeting with the physician, and where is that test done?
Yes, so either primary care physician or sleep specialist. Many types of physicians can diagnose sleep apnea, and the testing is usually done, particularly at Somerset, at our Hillsborough location. It's an outside lab testing site, or at the hospital for specialized type patients. And it is an overnight study, and the patient is brought into a private room where they are hooked up to various wires and stickers and belts to identify different parts of their physiology while they sleep. And a technician is with them through the entire night to monitor the test. And in the morning time, they usually leave the facility, and then usually from that, the interpretation of those findings, we can identify if sleep apnea is present.
So what we're going to talk about today is some of the patients who are determined to have sleep apnea might be candidates for a new kind of treatment. Dr. Lazar, yes. I understand that you're one of only a few surgeons in the state who are using robotic surgery for the treatment of sleep apnea.
Yes, it's a kind of pioneering new approach to addressing the tongue base in patients that have enlargement of the tongue base. Transoral robotic surgery is a new, innovative, minimally invasive procedure. The surgeon uses the robot to reduce the tongue base to alleviate or possibly even eliminate obstructive sleep apnea.
So, you know, some people may understand a little bit about surgery for different conditions or apnea without the robot. Can you contrast for us why the robot is different? How is it different than the traditional surgery? Is there a traditional surgery?
Well, for the tongue base, this area of the head and neck is difficult to reach, and traditional treatments or conventional treatments have fallen a little short as far as success rates. We've tried many ways to reach the tongue base, for instance, using radio frequency or other electromagnetic energy through needles to shrink up the back of the tongue base. We've tried to suspend it to stop it from prolapsing down into the airway by using a suture to suspend it to the mandible or other bony parts of the head and neck. And we've done transoral laser reduction of the visible part of the back of the tongue. But it's just difficult to reach that tongue and to treat it effectively and accurately to reduce it enough to actually treat apnea that's related to it. So for cancer surgery, it becomes justifiable to make larger incisions on the face, lip splitting, mandible splitting, large incisions that go down, tracheostomy, G-tube, to get rid of a cancer at the tongue base. But these kind of big incisions are not really justifiable to treat a non-malignant condition like apnea. So the beauty of the robot is access, and it allows sort of an unparalleled view for the surgeon to look down into the airway and accurately remove tissue. You're actually driving little arms of the robot remotely in a console next to the robot, next to the patient rather, to reach back there and debulk tissue to widen the airway and prevent the tongue from obstructing the airway during sleep that causes apnea.
So it's not an advancement or development in existing surgery. It's actually surgery that couldn't be done before.
It could have been done. It's just the approach wasn't really acceptable. I mean, yes, some people with extreme apnea have tracheostomy, and that's considered a kind of no other possible way to get around the tongue base kind of a procedure. Even that is a lot of people won't tolerate living with a tracheostomy tube in their neck very well. It's difficult.
So if a patient taken care of by you is determined to have sleep apnea, how do you figure out between the different specialties which patient is a candidate for robotic surgery, transoral?
Well, a candidate for robotic surgery has to be at least 18 years of age, and they have to have gone through a standard sleep study and have been determined to have obstructive sleep apnea before they're a candidate. Then they come to our office, we do a history and physical, we do an in-office nasal endoscopy to look at their airway anatomy and their relationships, their relative relationships of their airway, and the nose included and the adenoid included, to see where potentially their airway levels of obstruction occur. And then we take them to the operating room and do something that's relatively new called a sleep nasoendoscopy, which is when we try to put them into a drug-induced sleep state so we can mimic what they look like back at home in their bed in the operating room while they're sleeping and snoring. And we can use a telescope there and dynamically see them when they're sleeping. We can see where the snoring is coming from. We can see where the apnea is coming from. And then take this information and use it to have an anatomically driven treatment plan. So if their tongue base is very large, we could offer them something like transoral robotic tongue-based surgery now.
So you wake them up, you present their treatment plan. Some of them will not be a candidate, some of them will be.
True. Yeah.
And then you try to figure out what a good treatment plan is for them.
Yes, exactly. Hopefully with better accuracy, with better diagnosis.
Tell me a little bit about what can a patient expect. Let's say that they have the sleep OR study, you see the anatomy, and you think they're an appropriate candidate for TORS, and then they have the surgery. I mean, what can a patient expect? They come in the morning, in the evening, they're going to stay a day? I mean, what do they expect?
Right now, we're keeping patients in the intensive care unit for 2 days to watch them for airway and bleeding. These are very, we haven't had any problems as of yet, but it's a new program. It's a kind of a pioneering area in general, but this is one of the safest way to observe patients. And then they go home on pain medication, antibiotics, sort of a soft diet. They can expect to lose some weight over the month, maybe 10 pounds. Their tongue heals. It takes a little while for it to heal, and they usually are getting back to work in 2 to 3 weeks.
Is the ICU that's going to be at Somerset Medical Center that they would be staying there?
Yes, that's the only place I'm performing these procedures, at Somerset Medical Center, the Robotic Institute.
And that's done not because you know that something bad's going to happen, you're just being extremely cautious at this point?
It's conservative, and I think in the patient's best interest with a new procedure, a relatively new procedure, to keep a close eye on them.
And how do you judge what kind of success you've had? Like, do you see them again later, and do you need to put them to sleep again, or do they just tell you they feel better? I mean, how do you figure that out?
Well, in the patients that we've done so far, it's hard to get them to put their CPAP machine back on. So we've been, you know, I encourage them to use their CPAP until they come back in for their 3-month repeat sleep study, where we can then really more scientifically assess the success. Not just signs and symptoms, but physiologically see that they've changed. Early studies in the surgical literature have been very promising for this procedure, and that's why there's so much attention on it right now.
Now, you mentioned CPAP machine. Let me go back to you, Dr. Joshi. A lot of people who may or may not be a candidate for surgery are going to have other treatments for sleep apnea. Can you just go over that a little bit?
Sure. CPAP is by far the #1 treatment. And baseline, excuse me, moderate to severe sleep apnea, it's usually the first go-to option. CPAP stands for continuous positive airway pressure. It is a machine that's about the size of a shoebox. It sits right by the bedstand. The machine pulls in room air. It is not oxygen, it's just room air you breathe anyway. That once the air is pressurized to a given setting, the air gets delivered through a hose via a mask that sits superficially on the face. And what that tries to, and accomplishes it very well, is it creates an air splint in the upper airway system where the vulnerability for airway collapse occurs with obstructive sleep apnea. Because it hits all the different parts of the upper airway that are susceptible, it does eliminate snoring, apneas, which is the complete cessation of breathing, and hypopneas, which are the partial reduction airflow events. Now, there are other options, and of course, Dr. Lazar is talking about the TORS. There are dentists that also do oral advancement devices. They fit like a retainer on the upper and lower teeth, and it advances the lower jaw forward to then advance the tongue muscle. And the goal there, again, is to also increase the amount of room in the posterior airspace. Those are probably the three most common treatments. There's also something called positional pillow therapy. And for some people, sleep apnea can be very specific. Sometimes they have it worse on their back, or if a position severity is involved, and if it is where the patient does better on their side, these pillows have been designed to keep patients on their side, which is, again, specific to what the results of their polysomnography study kind of give us that roadmap to tell us where to go.
Now, so if a patient finds out that they have sleep apnea and they're getting a specific treatment from you or robotic surgery, I mean, they're in a position to benefit, to have an improvement in their quality of life. Are there a lot of people who don't know that they have sleep apnea?
Absolutely.
Yeah.
There's a pretty staggering statistic out there that 2% of men right now, 4% of women in general, but only 10% of the population has even been diagnosed or evaluated, discovered. So there is a very big population, close to 90%, that has the condition that remains undiagnosed.
And you mentioned a sleep study as part of it, and
Correct.
you mentioned we talked about talking to your doctor. Like, what things should make somebody think, let me ask myself, do I have sleep apnea? What kind of things do people report?
Snoring is by far the most common, and snoring is in itself a reflection of airway turbulence, which its bigger brother is obstructive sleep apnea. So snoring is by far one of the most common symptoms, but people can also report waking up with a difficult time catching their breath. People may have been observed to stop breathing, which is something we call witnessed apneas. On a more social basis, waking up feeling like you haven't slept at all, even though you may have given yourself 8, 9, maybe even 10 hours of sleep, waking up feeling unrefreshed, napping during the day when it's not acceptable to you. So there's lots of different ways that sleep apnea can present. Sometimes, very often in the office, we hear people just complaining of generalized fatigue, or even concentration and memory recall have been part of the symptomology of sleep apnea as well.
So you kind of hinted that it could be sleep apnea, but there could also be a lot of other conditions
Correct,
involving
yes.
sleep that could affect them.
Yes.
So, so what does somebody do if they think, oh, wow, I really don't get good rest, even though I'm lying down a lot? What do they do?
They should speak to their doctor. And as I said before, many types of physicians have the capability of screening their patients, almost every primary field, ear, nose, and throat dentist, many different types, almost every type of physician. There's some connection to sleep in terms of the benefits for their particular field, and in general, it is a general health concern. So the best first step is speak to your physician if you feel like this is a problem. And in terms of what they can do, they can obviously take the next steps with their physician. The sleep center, we have 2 physicians that work there as well. Then we see all general types of sleep disorders, including sleep apnea, and that would probably be the best first step.
Just mention 1 or 2 other sleep conditions that you see and treat to round out our understanding of sleep disorders.
By far, insomnia is one of the most common. That's, I don't know one person who hasn't had a bad night of sleep or a bad run of sleep, or even chronically years. Sometimes people suffer with difficult time falling asleep, difficult time maintaining sleep. Other conditions, some that are very common that are kind of coming in the media right now is shift work disorder, which is under the category of circadian rhythm disorders, which also play into jet lag, and the morning owls, the night larks, which are more scientifically phase delayed, phase advanced type people. And so insomnia, circadian, narcolepsy, the hypersomnia family is also pretty prominent in the practice, and those are probably the main ones that we, as well as movement disorders, restless leg, its cousin periodic limb movements that occur only during sleep.
Thank you for that overview.
Thank you. You're welcome.
Now, in addition, we were talking about sleep apnea today, but robotic surgery and ear, nose, and throat surgery, there's a lot of different conditions that you have an opportunity to take care of. Can you just give us an overview of that?
Sure. The whole concept of transoral robotic surgery started at University of Pennsylvania in 2004 with Drs. Weinstein and O'Malley, who are head and neck cancer surgeons. And the application was put toward cancers of the tongue, the tonsils, the throat, the larynx, and the base of the tongue. What these surgeons found was that they could not they didn't have to do the major incisions and the tracheostomy and the G2, the stuff I mentioned before. They could go in through the mouth, resect areas, and the patients had shorter duration of surgery, shorter stay in the hospital, quicker recovery, fewer complications, fewer need for transfusions, better quality of life. They got back to speaking and swallowing faster. Eventually it got approved by the FDA tours in 2009, and that's when other doctors like myself got on board to treat non-malignant conditions like apnea. And then there's also treatment of thyroids, transaxillary thyroidectomy, where there's an incision in the armpit, or through the face, through a facelift incision. The robot can be used to get to the thyroid without having to have an incision on the neck. So this is beneficial to patients who have cosmetic concerns.
So you were practicing before they even pioneered this way of taking care of patients. How do you get robotic training or become a robotic surgeon?
Well, there's a long training process involved with it, and of course, having the robot at your hospital helps. We have a terrific program at Somerset Medical Center. I went through Intuitive's training program, which is multifaceted. It starts with computer training modules, and then moves on to both pig and animal laboratories, then observation of cases at University of Pennsylvania, and then proctoring of the first 4 cases. So it was a long process.
Wow, thanks for sharing. So if you're a patient who is facing an ear, nose, and throat condition, and you're talking to them about possibly having robotic surgery, you know, tell us a little bit about that. How are you counseling them? What are they, you know, what should they understand about it?
Well, they have to understand that it is relatively new, that the surgical outcomes that are coming out are cases that have only been done over the last few years, that it is promising because of its accuracy, and as I've already said, the access to that area of the tongue that's so critical in airway collapse that can cause apnea. I think that you know, anyone who is really failing their CPAP or failing their oral device or just unhappy with it is a candidate and should consider it. It's not for everyone, and certainly the sleep nasal endoscopy is critical in making the diagnosis that it's actually the tongue causing the problem and not the tonsils or the palate or collapse of the pharynx or other conditions that can cause airway collapse that lead to apnea.
So, you know, we mentioned this one form of robotic surgery where your tongue is being operated on, and you're using a very cautious approach and having people stay in the hospital for 2 days.
Yes.
Do all patients who have ENT surgery with a robotic approach, do they all wind up needing 2 days of hospital stay, or some of them do? Well, some of them don't?
It depends what they're having done. You know, there's supraglottic laryngectomy. Those patients are going to stay in the hospital several days versus somebody who has tonsil cancer who may only stay in the hospital 1 day. So no, but for tongue base itself, the tongue is very vascular and it's important for speech. It's just a very critical crossroads in the back of the throat, and that's why we keep them, to make sure if they had bleeding, for instance, that's not something another physician maybe could easily take care of because of the location that we had to get to from a robot. So it's kind of important to have them there, so if they had a problem, we could take care of them immediately.
Some of the people who are candidates for an evaluation are people who've been treated for maybe many years even for sleep apnea.
Yes, some people have already had uvulopalatopharyngoplasty, or UP3, which is resection of portion of the soft palate, or they've had the layup, which is the laser-assisted reduction of the palate. And these procedures are, unfortunately, not as, you know, they don't really treat the apnea in the way that we hoped they did back when we were doing these years ago. I mean, there's still a definite role for all different types of procedures. It's a matter of applying them appropriately to the patient. But we used to feel that UP3 was the way to treat apnea, but now the concepts are changing as the diagnostic tools are changing.
Now, I learned from another time that you were educating our audience that overweight and obesity is a big part of sleep apnea and obstructive sleep apnea. Do you have any criteria where you'd like patients to attempt weight loss before they have the surgery? Is that part of the counseling process?
Absolutely, and I've referred patients to consider bariatric surgery or lap band or other kinds of ways to reduce their weight before they consider having their tongue reduced, because sometimes there's just no amount of tongue one could remove to, you know, treat apnea in someone who has multifactorial condition, and obesity certainly contributes significantly to apnea.
So this is not going to be a panacea necessarily.
Oh, no.
This is going to be a very carefully selected subgroup of patients who had these other approaches, tried other things, and have a
Yes.
certain tongue formation.
Exactly.
Okay.
That's collapsing, that's causing the problem that may have been underrated in initial evaluations.
So let's go back and just talk a little bit more about evaluating sleep apnea in general. So a patient talks to their doctor, the patient, the physician have the opinion that sleep apnea might be one of their issues, obstructive sleep apnea or another sleep disorder, and they come for an evaluation with a sleep specialist. Tell us what the sleep lab process is like. What does that entail? Is that difficult to do? Does it take a lot of time?
I mean, when they come for the overnight study? So the overnight study, is overnight, and we try to complement the patient's sleep schedule as best as possible. At either facility, Hillsborough or the one based in Somerset Medical, they come in the evening time, 7:30. They will be taken to a private room, and in the room they'll be meeting their technician, go through a little bit of paperwork, and about an hour, 45 minutes before their given bedtime, they come back in and they get them ready for the attachments of all the different devices that we use to enlighten us about the physiology, their breathing patterns, etc. The time it takes for setup is about 45 minutes, and the technicians put on various belts, wires, and stickers in different areas of the body. 6 go on the head, a few go around the eyes. There's a little microphone by the throat. There's a nasal cannula-like device and a sticker-like device between the nose and mouth, and those monitor the airflow. There are belts that capture respiratory effort that are upper and lower abdomen. There's a basic EKG on the torso and an oxygen monitoring device on the finger. And collectively, these give us an idea of what the patient's breathing pattern is like. We always preface the sleep study with, it's not likely going to be your normal night of sleep. It is a test after all, and there are going to be different parts of the night that may include the technician waking you up for a certain reason, or needing to come in and fix things if they've been removed or slipped out of place, to enhance the results and give us the best feedback as best as possible. There's also a video camera in the room that is also there to monitor the patient as well as identify their body position changes through the night. We usually wake the patients up pretty early, 6:30. That's relatively standard, and at that point they're free to go. And what we specifically do is we see them back about a week later after the test is done to go over all the results. And it's one of those necessary evils because it is the gold standard test, and because it gives us such a thorough and accurate amount of information, we can really identify what best treatment path they can follow after we get the findings.
And out of the patients who you determine have obstructive sleep apnea, how many do you think are appropriate, let's say, to get CPAP or some device at home to help them?
Yeah, that's a very common question. It's interesting because a lot of patients have different feelings about all the different treatments because they're so different. CPAP is very different from the oral device, very different from the surgical options, and depending on the level of severity, moderate to severe, I always try to use the first standard of treatment is CPAP. The cases that are milder or the severity is a little bit more waxing and waning depending on either body position or sleep stage, but overall, if it's less than moderate, I do open up all treatments to them. People can be treated with primary snoring with CPAP. It's sometimes really their choice, and I think a lot of people have preconceived notions about certain treatments, or the idea that wearing a mask is not, of course it's not ideal, but we always try to benefit the pros and cons of each treatment option, and for the most part, we push a CPAP when it's really the more severe cases. But otherwise, I find that everyone kind of has a different perception, and it's hard to put a percentage on that. So we try to guide them in the best direction possible.
Do you have any patient stories that you remember where people experienced significant relief, or do you have any patient stories where people were describing to you the difference after the treatment and what kind of difference it made in their life?
Yes, we've had some patients say things like, I've never liked my bed before, now I like going to sleep. Or I don't have to get up in the middle of the night to use the bathroom anymore. I used to get up 4 times, which is a sign of apnea also in some patients. People who, their wives and husbands comment that they're sleeping quietly. They used to make so much noise that to, kick them to make sure they're breathing still because they're more silent. So yes, and those are, so far. We've gotten a lot of nice feedback from patients.
And it's interesting she mentioned bed partners. They often accompany the patient to the visit, and after the fact, once we get them on a treatment protocol, the bed partners are much, much happier. And the question from the patient, which is interesting, is always, you know, how loud is the machine? And I have never heard any bed partner complain about what I described, the sound of the CPAP is like a room air fan. It's pretty consistent. It's kind of that white sort of background noise, but no one ever has said, I'd rather hear them snore and wake up choking, you know, and being concerned about their bed partner over, again, the CPAP. So it is a lifestyle adaptation, and oftentimes, you know, one benefit for sure is patients who are on very high pressures. A lot of times we allocate the resources of what Dr. Lazar does to sort of help if a patient is debating over the full surgical option. Sometimes whatever surgery that can be done can help reduce the pressure requirement for CPAP. So that's something that we lean on a lot of the other treatment options to help if the patient still wants to remain on CPAP, but the pressure is still a little too overwhelming for them. So that's another.
You both have mentioned that, is that many of these patients who benefit from the surgery are still going to use CPAP. It's not something that you even counsel them that they're going to be able to do without. It's just something that will improve their quality of life and their breathing. And we talked on the other show about all the negative health effects when you don't have proper sleep. It's not just your subjective sense of sleep that deteriorates. Your health deteriorates in a lot of other ways. You know, it's worth mentioning that again.
Sure. Sometimes we're simply fixing the patient's septum and reducing some of the swollen membranes in their nose so that they can move from a full-face mask onto a nasal cannula mask, which is the nasal cushions, which is a lot more comfortable for patients. So it often makes it more tolerable, and they can move on. Certainly CPAP is less risky than undergoing surgery, and it treats the disease with more of a guarantee.
So you mentioned you know, an overview of sleep disorders, how patients might determine that they themselves are a patient who deserves attention if they have a sleep disorder. We talked about the sleep studies, the sleep center, that consultation. We talked about the possibility of having robot surgery. Is there any one last thing you'd like to emphasize before we wrap up?
I always stress to patients and healthcare workers, snoring is not normal. And it never was and never will be. It definitely has gone to our popular culture as acceptable. However, it is not, and if it is there, it should be addressed.
And I just want to say that there is hope out there for patients with challenging obstructive sleep apnea. There's 2 more treatments, or at least modalities, on the horizon: sleep nasoendoscopy on the diagnostic end, and transoral robotic surgery for patients who have really bulky tongue base. So never give up hope.
Thank you both very much.
Thank you.
That concludes this episode of Somerset Medical Center's Health Talk. Please remember that the opinions expressed here by our medical experts today are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral number at 1-800-443-4605. For more information about robotic surgery or sleep apnea, visit somersetmedicalcenter.com.